Okay, good morning, everyone. Today we are going to discuss about the case of chronic cholecystitis. Now, this is a very straightforward and simple discussion, to be honest. But in the last prof that I have been present there, and I have seen quite a number of students were confused about some of the important things. Now, during the clinical examination or as a long case, the examiners don't really want a very in-depth discussion. It goes very superficial. They just want a good presentation. And a few simple questions are being asked. And once they think that you're a very good student, then they might ask you a few in-depth questions. But before that, you don't have to go into those very broad discussions. So today I thought that it would be necessary to discuss a little bit about this simple case as a long case, a case of chronic cholecystitis. Now, so we start with, as usual, the particulars of the patient. Age may be important or may not be important, but as you remember that the 5F, if you remember it, that age of 40, female, fertile, fair, fatty patients are more prone to this sort of diseases, but certainly males are equally prone to this disease. But usually, if you may find quite a number of female patients who are above the age of 40 years. What can be some of the presenting complaints? Now, there's a bit of confusion. Sometimes the only complaint is the recurrent pain in the upper abdomen, which is actually is the commonest complaint. And I also see a lot of patients coming to us with indigestion, or in the more medical term, it's called dyspepsia, right? So people might come to you with those symptoms, but usually what happens is a patient with indigestion goes to a gastroenterologist and who does some investigations like ultrasound. And when they find out that the patient is having gallbladder stones, and when they refer the patient to the surgeon, that's what happens. Recurrent pain, patient may also complain of nausea, vomiting, or maybe fever as well. But the commonest complaint is the recurrent pain in the upper abdomen. That is the commonest complaint. You can also add right upper abdomen if the patient is very specific where the problem is. You can say right upper abdomen. Most of the patients are not very specific and then say it's in the upper abdomen. Okay. So let me see if I can remove this. Okay. So history of present illness. Now I have written a sort of quite a broad history of present illness. You can shorten it according to the history of the patient. Now what happens is you should remember what are the different presentations may be. Different presentations, patient may come to you with acute cholecystitis, right? Patient may come to you with chronic cholecystitis, or may even be acute and chronic, right? Or maybe just biliary colic. So these are actually the 4 presentations that maybe the patient may come to you with those. But I have tried to incorporate all of them here. I will discuss them individually. Usually what happens is, usually the first presentation, the first time the patient is having the pain is the biliary colic. The first time the patient is having the pain is the biliary colic. After few attacks, then the patient has acute cholecystitis. And the patient takes some medications, maybe some antibiotics, maybe some analgesics. And later the disease is converted into a chronic cholecystitis. And there may be some acute exacerbations as a result of acute and chronic cholecystitis, right? So features would be similar, but there are some of the clinical features or the symptoms which you can differentiate from each other. So you can start your history of presenting illness like this. According to the statement of the patient, he was reasonably well about 6 months back. Then he felt a sudden pain in the right upper abdomen, which was colicky in nature, severe in intensity, radiating to the tip of the right shoulder. It can also be just the back. Most of the time, the patient has difficulty in differentiating whether it's the back or the shoulder. So patient can say different things. Lasting for an hour. Usually, if you from the history, you can understand that I am trying to describe biliary colic. Lasting for an hour, aggravated after taking rich food and relieved spontaneously, and associated with nausea, and may also have some vomiting as well. So if you look at this patient, the patient is just having pain. The patient is not having the features of other features of inflammation like fever. So this is actually the first time what happens is the stone, what happens, let me see if I can get a page. Okay. What happens is, if this is the gallbladder, this is the right and this is the left duct. What happens is the stone gets stuck in the Hartmann's pouch the first time, and there is severe contraction of the gallbladder trying to expel its bile, but the gallbladder fails, and there is severe colicky pain at this time. But as there is no inflammation, usually there is no fever, but patient definitely may have nausea, vomiting. And what happens is, it is usually it's relieved spontaneously. But yes, there may be sometimes the patient may say that I took some strong analgesics to relieve the pain. That can happen. But usually the time is around about a few minutes to few hours, maximum 3 hours, I think. Usually it does not last more than for 3 hours. But what can happen is that recurrent such attacks would lead to acute cholecystitis, when the patient may have fever. Let's see how the disease progressed. Over the last few months, he had multiple attacks of such pain. Over the last few months, they had multiple attacks of such pain. So there's recurrent, multiple episodes of such pain. For the last 2 months, pain is constant aching in nature, and the pain is lasting longer than 3 hours and associated with fever. Now, what is happening is the colicky pain has converted into a constant aching in nature. Now, remember, not all the patients can give us such a beautiful history. So if the patient can't give you a history of the colicky pain converting into a constant aching pain, don't be confused, because whenever the patient is in severe pain, the patient usually does not remember what type of pain she is going through. So this is what happens. The biliary colic now has converted into a acute cholecystitis. And long term, when there is acute cholecystitis, what happens is there is fibrosis. There's fibrosis of the gallbladder, and gallbladder cannot expel the bile. It becomes a rigid structure. The wall is thickened. And after some time, patient also complains of upper abdominal discomfort, bloating, feeling of fullness, nausea after taking meal. These are the features of, as you can understand, flatulent dyspepsia. Flatulent dyspepsia. What happens is, this is usually after a rich meal, usually after high fat content. What happens is there may be heartburn, there may be reflux, there may be upper abdominal discomfort, pain, bloating, feeling of fullness, nausea, and vomiting. This can happen. This is a very specific feature of cholecystitis. You can have similar features in reflux gastritis as well, but actually from this history, you can understand that the disease has converted into a case of chronic cholecystitis. he has lost about 2 kg of weight, which is not significant due to loss of appetite. This appetite may be a direct cause of the disease because the patient is scared of taking food, because every time the patient takes food, there is some discomfort in the abdomen. His bowel and bladder habit is normal. Now, this is one way of writing the history. The patient may not be able to give you such a nice history. The patient may come to you with only the history of flatulent dyspepsia. Patient may say that I don't have any pain, but I always have some discomfort after taking food. I have fullness, I have bloating, I have some heartburns after taking meal, and for which the patient went to a doctor, especially a gastroenterologist, and who has done some investigations and found out that the patient is having cholecystitis, which is actually a feature of chronic cholecystitis. But if it is an acute cholecystitis, there will be severe pain, there will be fever, there will be vomiting. So disease history or treatment history or drug history, whichever way you want to write it. Oral contraceptive pills. This is important. Usually the female patients above the age of 40, they take oral contraceptive pill, which causes stasis of the gallbladder and which may result into formation of gallstone. Clofibrate is another lipid lowering agent, which is also said to have some effect on the gallbladder in forming stones. Estrogens also have some features. Terminal ileal disease. Now, why this is important? Because if you remember the enterohepatic circulation, the bile salts, which are secreted from the common bile ducts into the second part of the duodenum, which ultimately goes to the terminal ileum. But if from the terminal ileum, this is absorbed and this goes back to the liver. This is called the enterohepatic circulation. You remember that, right? Because the bile salts are very important constituent of bile, because the bile salts keeps the cholesterols in solution or the lipids in solution. So these bile salts and phospholipids, these are absorbed from the terminal ileum and goes back to the liver, and they're again secreted. So if the bile salt is lacking, there is a good chance, there is a ratio usually, like cholesterol is to bile salt, 1:20 if I remember it correctly, or maybe 25. Whatever the ratio is, it's not very important. What is important is if this ratio, the cholesterol becomes higher, then what happens? There is always a chance of stone formation, and bile becomes lithogenic. I mean, that means there is a tendency towards formation of stone. So the bile salts, which keep the cholesterol in solution, if there is a decrease in the amount of bile salts due to terminal ileum disease, when can there be a terminal ileal disease? For example, you have resected the terminal ileum for some disease. For example, Crohn's disease. Crohn's disease, a disease which involves the terminal ileum. The Crohn's disease involves the terminal ileum. The tuberculosis, usually the intestinal tuberculosis, usually involves the terminal ileum. As a result, if there is a surgery is being done in such a patient, we remove the terminal ileum. And as a result, which hampers the enterohepatic circulation, and there is always a chance of formation of bile salts. Even sometimes we find out that some patient who has ileostomy, some patient who is having an ileostomy. If you're having an ileostomy, these patients sometimes come to you with abdominal pain, and if you do an ultrasound, you might find the patient has a gallstone. So terminal ileal disease, or you must take a surgical history whether the terminal ileum is present or has been surgically resected. Cholestyramine therapy is also another drug that has been said to have this effect, probably the similar way, again by stasis of the gallbladder. Personal history of smoking and alcohol, they are almost involved in all diseases. But diet, high caloric diet, that means which causes increase in cholesterol. and which causes, if you remember, the cholesterol is to bile salt ratio, which is something around about 1:20. If the cholesterol increases, the bile becomes lithogenic. The bile becomes lithogenic. And as a result, there's a more chance of stone formation, even if you're having a high caloric diet. Family history. You can definitely remember whenever you are taking the history of a patient with biliary pathology, but you must always remember the differential diagnosis. It's very important, which are peptic ulcer disease and pancreatitis, which are the commonest diseases. So always make sure that you take the history of these diseases as well. Now remember that how can you differentiate? Peptic ulcer disease, usually patient comes to you with a burning pain, usually in the slightly on the left side of the abdomen or in the epigastric region, and the pain is not colicky. In this case, the pain is colicky. In case of chronic pancreatitis, what happens there is the pain is severe, sometimes may radiate to the back, and patient usually has weight loss and diabetes. So these are some of the ways you can differentiate between the biliary pathology and pancreatitis and peptic ulcer disease. As to the family history of pancreatitis, peptic ulcer disease, and biliary history, though I agree that they are not always very common, the patient may have no family history of such diseases, but always family history. If you have a positive family history, that always supports the disease. Menstrual history, take the history of whether the patient is taking any oral contraceptive pills. Immunization history may be important. Now, on general examination, what you may find the patient to be obese, and the patient may have no other features. The vital signs may be normal, may not have any anemia, jaundice, or any other features. But yes, the patient, if the patient comes to you with acute cholecystitis and with recurrent vomiting, there may have some finding in the hydration status. Patient may be dehydrated, right? If the patient has acute cholecystitis, then the temperature, patient may have fever, the pulse may have tachycardia, patient may have tachycardia. So these are some of the features that may be present if the patient comes to you with acute cholecystitis or acute and chronic cholecystitis. On abdominal examination, usually in inspection, we do not find any pathology. On palpation, there may be tenderness in the right hypochondriac region. Murphy's sign, this is very, very important. Remember to correctly elicit this sign, because this will always be asked in the long cases. If you're having a case of cholecystitis, the examiner will always ask you to show him the Murphy's sign or how you do it. What happens is, if the patient is in supine position, and if this is the chest, let's say this is the diaphragm, and let's just say this is the liver, and if let's say this is the gallbladder. So what happens is, if you put your thumb over here at the tip of, where do you do it? They'll always ask you, how did you find it? If this is the umbilicus and this is the jiffy sternum, their midpoint where they cut it, the costal margin, this is the point. This is the tip of the 9th costal cartilage. So at this point, you put your thumb here, right? So what happens if the patient is having an acute cholecystitis and you put your thumb here at the peak of inspiration, when this gallbladder hits the thumb, there is a sudden cessation of inspiration. There's a sudden cessation of inspiration because this is very, very tender, right? Because it's acutely inflamed. So you have to understand what the Murphy's sign means, and you must be able to correctly elicit this, because if you can't do this, this is a very negative sign for the examiner. So Murphy's sign must be elicited. Any palpable lump. When there can be a palpable lump? If there is a mucocele. If there is empyema of gallbladder. So why you may have an mucocele? What happens is, if this is the gallbladder and the stone is stuck over here in the Hartmann's pouch, what happens is there is a mucus secretion, constant mucus secretion, and the gallbladder enlarges, right? Distends. And sometimes when the gallbladder distends so much that it reaches the lower edge of the costal margin, you may be able to palpate the gallbladder as well. So if this is a palpable lump, painless palpable lump, that means it's a mucocele. If it's a painful palpable lump, it should be an empyema. Percussion, usually you don't get any important findings in percussion. Auscultation, you have to check for the vowel sounds as well. So the salient features, certainly you can write your salient features your own way, but try to make it as short as possible because long salient features are not liked by the examiners. So this is how I write the salient feature. Always remember that you can always criticize my way of writing. You can also have your own way of writing it. There's many ways of writing it. Now I have given quite a number of exams, and always I have written my salient features like this. And sometimes I did find some criticism from the examiner, but more or less they were okay. So I think this is, if you write your salient features like this, you shouldn't have a lot of problems. So Mrs. Y, 45 years, a teacher from Borisha, was admitted to this hospital with the complaints of recurrent colicky pain in the right hypochondriac region, radiating to the tip of the right shoulder. Now, what I'm doing here, look at this. I am deliberately telling my audience, telling my examiners that I am going in the direction of cholecystitis. I am not writing about all the features. I'm writing about recurrent colicky pain and radiating to the tip of the right shoulder. Features which are very much suggestive of cholecystitis, associated with occasional fever and vomiting for 6 months, and also has flatulent dyspepsia. Flatulent dyspepsia. This is dyspeptic features or upper abdominal features like pain, discomfort, heartburn, nausea, vomiting, feeling of fullness, early satiety. These features after taking food, especially fatty food, for 4 months. He's also taking oral contraceptive pills for 5 years. On general examination, the patient is overweight. This is probably the only finding that I have, which may support the diagnosis of a cholecystitis. The patient has a BMI of about 25 kg per meter square. If you can find out the BMI, that's a very good. That gives you some extra marks. She has mild tenderness. There may or may not be any tenderness in the right hypochondrium, especially if the patient is having chronic cholecystitis. There is usually no tenderness in the right hypochondrium. Murphy's sign is negative. Always make sure that you elicit this sign correctly, because Murphy's sign, if it is positive, then you have no other way but to go for acute cholecystitis. And you understand that in an examination hall, they will not give you an acute case, right? So even if you elicit this sign, try to use it intelligently. So provisional diagnosis, chronic cholecystitis, probably due to cholelithiasis. First thing is, why did I say chronic cholecystitis? Because there is pain in the right upper abdomen, which is now a constant aching in nature, which is no longer colicky. And the patient has flatulent dyspepsia. Flatulent dyspepsia, right? So these are important features which are suggestive of chronic cholecystitis. Certainly, if the patient is also still having, if for example, in your case, the patient is still having fever and Murphy's sign is positive, then you can definitely confidently say that this is a case of acute cholecystitis. But without fever and the MRCP is sign positive, this is not a very, I don't think it's a good idea to write acute cholecystitis. Then you go for chronic cholecystitis with upper abdominal pain and flatulent dyspepsia. There are enough findings to support chronic cholecystitis. Next question the examiner is going to ask you is, what are your differentials? Certainly you can say chronic PUD, but chronic peptic ulcer disease and chronic pancreatitis. Next question that will be asked by the examiner is, why not peptic ulcer disease? Usually in case of peptic ulcer disease, the pain is around in this area. And in case of cholecystitis, usually the pain is in and around this area. Certainly the patient sometimes won't be able to differentiate this, and patient will say, I have an upper abdominal pain. That can also happen. Usually in case of peptic ulcer disease, usually it's a burning pain. It's a burning pain, not a colicky pain. Never will a patient with peptic ulcer disease come to you saying, I am having a colicky pain. Peptic ulcer disease also has no fever. No fever, never. If there's fever, there may be perforation. The peptic ulcer disease comes to you only with pain and nausea, vomiting, but no fever. And the peptic ulcer disease patient also may give you history of association, sometimes association with food. Sometimes what happens is, if the patient, it depends whether the patient is having a gastric ulcer or a duodenal ulcer. So according to that, there may be an association with taking food. I will, if I get a chance another day, then we will discuss about peptic ulcer disease as well. Chronic pancreatitis. Now, one of the important findings, definitely through the pain, it's difficult to differentiate between the pain of chronic cholecystitis and chronic pancreatitis because they are both very similar. But one thing that happens usually in pancreatitis is weight loss and diabetes. Usually, they certainly can be absent, but these are the two features that are very suggestive of pancreatitis, which are not there in case of cholecystitis. And in case of pancreatitis, if you remember, if it's an acute and chronic pancreatitis, a severe agonizing pain. So the pain, the severity of the pain is also very high, but usually the history given by the patient usually is quite difficult to differentiate between the two things. So what are the investigations that we'd like to do? First, we want to confirm our diagnosis, and the best investigation to do that is the ultrasound of the whole abdomen with special attention to hepatobiliary and pancreatic system. We also would like to, if you are thinking that the patient is having a peptic ulcer disease, then it may go for an endoscopy. If you think the patient is having a pancreatitis, you may think about amylase and lipase. If you remember, the lipase is more specific than amylase for pancreatitis. To assess the general condition, one of the investigation, liver function tests you also should do, because sometimes in liver function tests you may get increased bilirubin and increased alkaline phosphatase, which is the features of obstructive jaundice as well. There may be features of obstructive jaundice. So do the liver function test as well. Other investigations for the fitness, general fitness of the patient for anesthesia, you have to do complete blood count, chest X-ray, ECG, and others. Now, in case of ultrasound, what are you going to get? If this is a case of acute cholecystitis, you will get slightly thickened wall. If you remember, the wall thickness is usually normally 3 millimeters, usually less than 3 millimeters. But if it is more than that, like this, thick wall due to edema, features of acute cholecystitis, there may be pericholecystic fluid, and there is a gallstone with posterior acoustic shadow. The gallbladder is stuck in the Hartmann's pouch. So this is a case of acute cholecystitis. Acute cholecystitis. What are the things you are going to get? You'll get a gallstone with its posterior acoustic shadow, you get a thickened wall, and you get a pericholecystic fluid. These are the features of acute cholecystitis. These are the sonologic features of acute cholecystitis. Another very interesting finding is sonographic Murphy's sign. What happens is the sonologist, if this is the probe of the sonologist, if you remember, it's a T-shaped, usually a T-shaped probe, right? So whenever with the probe, the sonologist presses on the patient's abdomen, and if the gallbladder is somewhere around here, there will be pain, right? It's sort of a Murphy's sign type of examination. So sonographic Murphy's sign, pressing with the probe on the right hypochondriac region, there will be tenderness. So this is sonographic Murphy's sign. Another thing, this is a very nice picture. If you look at this, this is the gallbladder. Within it, this is the stone. And this is the common bile duct. There is another stone over here. So it's very important. What are the things you'd like to assess? The gallbladder along with the biliary system, right? So if you check the biliary system, there is another stone. So this is a case of cholecystitis with choledocholithiasis. This is a very nice picture. Look at this of acoustic shadow, posterior acoustic shadow. Okay, this is a similar picture. And this is associated if there is a pancreatitis. If you look at this, there here somewhere around will be the gallbladder. And this is the pancreas. There's multiple stones, hyperechogenicity due to calcification of chronic pancreatitis over here. If this is the case, you can also go do an X-ray of the abdomen as well. This is the abdominal X-ray, and you can see the pancreas is calcified. Calcification. If you look at this, this is the L1. So at the level of the L1, L2, there is calcification, meaning the pancreas has been calcified, which is a feature of chronic pancreatitis. Liver function test. Remember to check the alkaline phosphatase, which may increase. The bilirubin, which may increase. So these are the features of cholestatic jaundice as well. If these features are present, that means if you think there is cholelithiasis with stone in the gallbladder, you can go for an MRCP. When we do that, whenever there's a history of jaundice, elevated liver function test, and dilated common bile duct, or any suspicion of stone in CBD, common bile duct, you do a magnetic resonance cholangiopancreatogram. So what's the treatment? Now, if your diagnosis is acute cholecystitis, you can certainly talk about surgery, but usually what happens is in case of acute cholecystitis, we initially go for conservative treatment. Don't say resuscitate the patient. Say we go for conservative treatment. That is, you give medications. What? You give some IV fluids. You give some antibiotics. So antibiotics like ceftriaxone maybe. If you take severe infection, maybe you're going to give metronidazole, but ceftriaxone is okay. You give some analgesics. You maybe give some proton pump inhibitors, maybe some antiemetics. You may have to catheterize the patient as well to monitor the input-output of the patient. So these are the few things that you'd like to give the patient and do the conservative treatment. When the patient's sign symptom improves, after 6 weeks, you go for laparoscopic cholecystectomy. Now, if someone asks you, in case of acute cholecystitis, would you like to go for surgery? Your answer should be that, sir, I would like to go for conservative treatment, and after 6 weeks, I'd like to go for surgery. Why? Because in case of an acute case, the tissue is very friable, and there's a lot of dense adhesions, and it would be very difficult for me to do the surgery perfectly. But with expertise, if you're an expert surgeon who has been doing these operations for a long time, they can certainly do a case of acute cholecystitis. So it is possible, it is not an absolute contraindication, but in your case, to be safe, you say, I will go for conservative treatment. And after 6 weeks, I'll go for laparoscopic cholecystectomy. Yes, but after conservative treatment, I will definitely monitor the patient. And if I see that the patient is deteriorating, patient's fever is rising, pain is rising, there is a lump, there's a features of empyema, then I will immediately go for surgery. And it depends with laparoscopic or open. You can talk about open surgery as well. If you say that I don't have enough expertise, there is nothing bad in saying that I'm not expert enough and I'll go for an open surgery. Because remember, the examiners want you to be a safe surgeon. They don't want you to be what should I say, a very adventurous surgeon. What they want is, what happens is the patient needs to be safe. And to do that, you do whatever this is necessary. If you think that this surgery, I can't do it laparoscopically, then you confidently say that, sir, I don't have enough laparoscopic expertise and I would like to do it in an open manner. But don't always say that I will refer this patient to another surgeon. That is embarrassing. I mean, then the examiner will ask you, then why are we examining you? So say, I will do the surgery, but in a different way. I'll do it in open or laparoscopic, whatever expertise I have. Sometimes commonly they ask why you want to go for laparoscopic cholecystectomy, because there's less pain, less hospital stay, cosmetic, early return to work, and you remember all the many things that are written. So go for that. The patient, what happens? You don't have a long incision. You have very small incisions, right? So pain is less medication, less cost. Usually what happens is the medicine cost is less, but what happens is the laparoscopic surgery usually is slightly more expensive than the open surgery. In case of the surgeon, why it is difficult? Because there's a long learning curve and there's no tactile sensation. That means there's no touch sensation in case of a surgeon. You can't feel it. That's a big problem for the surgeon. So you have to overcome that if you want to learn laparoscopic surgery. So short incision means it's a cosmetic incision. It heals early, there's less pain, and early return to work. Postoperative long-term complications like incisional hernia are very less, but yes, there may be port hernia as well. So some of the few things that I would like to discuss is, commonly the examiner will ask you the ports. What are the ports? The first port is the umbilical port. This is a 10 millimeter port, right? This is a 10 millimeter port. What happens? Through this port, we introduce the light, the camera, and the gas, right? What is the gas? The carbon dioxide gas, right? Why we use carbon dioxide? Because it is non-inflammable. If you use oxygen instead of carbon dioxide, and if you use diathermy, there's a chance that there may be an explosion. So we use carbon dioxide gas. The camera, or we actually insert, not the camera, we actually insert the laparoscope or the telescope, right? Through this port, and the light as well. Then there is another port in the epigastric region. This is also a 10 millimeter port. And there is another 5 millimeter port in and around the anterior axillary line, or you can say in the right hypochondriac region. These two are the working port. These are the ports used by the surgeon. And there's another port near the mid axillary line, somewhere around here. This is the port which is used by the assistant to hold the fundus of the gallbladder, right? You must remember that these two ports should never be on the same line. Remember this, these two ports should never be on the same line, then they'll be very difficult for the surgeon and the assistant to work. So what happens in a laparoscopic cholecystectomy? You first hold the Hartmann's pouch, and you dissect the calyx triangle. What is the calyx triangle? For example, if this is the gallbladder, and listen, this is the common hepatic duct, and let's say this is the liver. So above is the inferior border of the liver, below or laterally is the cystic duct, and medially is the common hepatic duct. In between is the cystic artery. There is also another cystic lymph node of Lund over here. So you dissect this, you clip the artery first, and then you cut it. Then you clip the cystic duct. Always remember the cystic duct, usually proximally we give 2 clips, distally we give 1 clip, and then cut it in between. And lastly, we dissect the gallbladder from the liver bed, and then we extract it. It can be extracted through the umbilical port or the epigastric port. Commonly, we use the umbilical port for extraction of the gallbladder. I don't think anything further will be asked during the examination. Another thing is in open surgery, in case of open surgery, what incisions can we use? We can use a, we can use a right subcostal incision. When this incision is extended to the midline, it becomes a Coccus incision. We can use an upper midline incision. We can use a right paramedian incision as well for cholecystectomy. Now, what are the complications? Early complications, access, it can be divided into access complications and bile duct injuries. What is access complication? This is in case of laparoscopic cholecystectomy. When you're introducing the port, there may be injury to the bowel. Bile duct injuries, why? Because if you remember the previous slide, always the common bile duct or common hepatic duct are very close to the area of dissection. Then there is a chance that these ducts may be injured. Especially, I have seen quite a number of times that the right hepatic duct has been injured. So remember this, the right hepatic duct is injured more than the left hepatic duct. Dissection of this area, it must be meticulous. We always do a posterior dissection first and then the anterior dissection. To understand all these things, you should go to the operation theater and see these surgeries. I think the teacher, the professor would be glad to show you how they do the surgery. Bile duct injury, commonly the common bile duct can be injured. Now what happens? For example, if there is a bile leak after the surgery, let's say the patient is on the first POD or the second postoperative day, and you see there is a localized tenderness over there, and probably a lump in and around the operative area. Patients may have high temperature. The patient may have high pulse. The BP may be falling. In such a case, always think of an injury to any hollow structure, especially the bile duct, and probably there is a bile leak. Immediately go for an ultrasound. If you see that there is a collection over there, do an ultrasound guided drainage. If you don't have the facilities, then do a operative management. You can open the patient, or if you have laparoscopic skills, do the washout through the laparoscopic ports. But always remember, any complications postoperatively, the first investigation that you should do is an ultrasound. And always never be scared to say that if you, for example, if you are a general surgeon and if you think that if you don't have the capacity or don't have the ability to repair one of the bile duct injuries, then always you can refer it to a specialized center. But before that, always put a drain. This is a life-saving procedure. Put a drain over there. Don't let the bile accumulate within the abdomen. Just let the bile come out and the patient will be absolutely okay. I have seen many patients in whom the bile has been leaking for 15, 16 days and the patient is absolutely okay. So it's not a permanent procedure, but this is a life-saving procedure, which will give you time to decide what to do with this patient. And in case of late complication is the post-cholecystectomy syndrome. This is similar to flatulent dyspepsia, abdominal pain, and all these things. What the patient will complain that even after the surgery, the patient is having the same problems. So you have to again do the investigations to check for whether there is another stone remaining in the common bile duct. That is the thing what you want to find out first thing. If you don't think there is a structural abnormality, then conservative treatment, give the patient some antipsychotics, give the patient some antispasmodics, give the patient some proton pump inhibitors, and the patient will be okay. Another thing commonly asked by the patient is what are the complications of gallbladder? You know that what are the complications of gallstones? In the gallbladder, it may be silent. Many of us are having stones in our gallbladder, but it is asymptomatic. There may be acute cholecystitis, chronic cholecystitis, mucosal empyema, rarely carcinoma. This is very rare, but can happen. In the bile duct, obstructive jaundice, recurrent cholangitis, pancreatitis. In the stone, gallstone ileus. These are some of the questions which are loved by the examiner, so they will ask you these questions. Theories. What are the theories of gallstone formation? The metabolic theory. This is the theory which I have been discussing. The cholesterol is to bile salt. The ratio should be around 1:20. Correct me if I'm wrong. I think it may be 1:25 or something like this. But basic thing is that this should be the ratio. And if the cholesterol level is going up, then the bile becomes lithogenic. That means the cholesterol can no longer be in solution and they accumulate, they aggregate or they nucleate together and they form the cholesterol stones. What are the three types of stones? The three types are cholesterol stones. The pigment stones can be brown or black pigment stone. Brown stone is usually due to infection. Black is usually due to hemolysis. And there's mixed stone. The commonest type of stone in Bangladesh is the mixed stone, right? Stasis. There may be stasis. If you remember that we have been talking about oral contraceptive pills, which causes stasis of the gallbladder, or long-term fasting, sometimes fasting for a long time, causes stasis, which may result into bile stone formation. Infection. This causes the pigment, the brown pigment stone. Usually one of the commonest bacteria is the E. coli. So these are the few of the things that would be asked. Go through the book. I think Bailey and Love is quite a good book at undergrad level. If you are a postgrad student, then I think for this, I think the Cushieri would be a better book to study than Bailey and Love. Bailey and Love is concise, but at undergrad level, I think this is more than enough. And go through your examiner, the professor's note. I think there will be more than enough. We do not have a lot of time, so I always try to compress everything in one lecture. But my main target is to teach you guys how to take the history. If you guys have any further questions, feel free to ask me. And if I have missed something, you can also tell me about it. Maybe in the next few other classes, I can discuss those things. You can ask me any questions you want. So thank you for your time, guys.